சரியில்லைன்னா வந்து அப்பா கிட்ட உங்களை பத்தி சொல்லிட்டு இருந்தேன்.
Sir, good evening, sir. Can we start, sir?
Good evening, sir. Good evening.
Good evening, sir. Can we start, sir?
Yes, you can start, sir.
Yeah.
It's time 7 o'clock already.
Yes, sir. So I sincerely thank the APA and ICP chapter for giving this wonderful opportunity. After a brief breakdown, after a brief break of Holi, like people celebrated, now we are joining again. What we are trying to do in this course is, this session is basically, we have completed 4 sessions. That means the basic module has been completed. How to approach infectious disease in the first module. In the second module, how the microbiologists or how the clinician should approach the microbiology lab. And in the third part, we have discussed about the FEO or PO approach. And fourth part, we have discussed about the antibiotics. This part is combinations of all the 4. So those who missed in the previous sessions, we know what we are dealing with in the first part. So this is a first session of the infectious diseases getting over today. Before I start the sessions, I asked the Dean of ICP to give words of introductions and share his words of wisdom for today's session there. Kamlesh, sir?
Okay.
It's okay on that, 1 second. Sir, your words of wisdom for session, sir? Kamlesh, sir? Yes, sir, audible, sir, no? I don't think, I think some issues with Dr. Tiwari sir's connection. So we'll start the sessions and I'll ask Dr. Tiwari sir to give a concluding remarks at the end, since we are running late of short of time there. So today, as I told, what we are going to do is the 3 or 4 sessions who people who have missed it, you can join today and you can get the inputs from last 4 sessions there. So this is basically all practical case-based discussions only I'm going to do. Before that, my disclosures, I don't have any disclosures except the ID doctor, and this is not prepared by AI. Nowadays, we know people are making PowerPoint presentations with AI involvement. This is not AI involvement. This is my own brain. That's what we made it today there. So I'll straight away begin with a case here. So the topic is clinical clues in infectious diseases. So this person, 28-year-old male, basically is working in Chennai, presented with fever of 8 days durations. The other complaint is diarrhea of 4 days durations. On examinations, he was febrile, spleen was palpable. Similar febrile illness twice in the last 2 months. Treated with 5 days of short courses of antibiotics. Started this time with levofloxacin. On day 4 of levofloxacin, still the person has got fever. He is native of neighboring Bangalore, eating at different places in Chennai because he's staying in Chennai and working in Chennai. So he's eating different sorts of places there. And somebody did the Whitehall test because they assumed this is a typhoid, and they did a Whitehall test. Whitehall test came back as negative. So what clinical cue is good in this case for your diagnosis? First things, what is your diagnosis? For the diagnosis, what is the clinical clue? I asked the participants to put it in the chat box. I want to put it in a what do you call online like a polling app, but unfortunately that only took time. But unfortunately that was not succeeding. A lot of technical glitches we faced with the online polling app, but finally it's okay. But you can put it in the chat box so that almost 67% joined. So we check how many people are answering this one. Right now people are entering the name. I have not seen any responses so far. So what do you think? What is your clinical clue in this case? I've shown a lot of clue for you people. So this is basically a case-based discussions. A lot of time is there. Please go ahead and put it in the chat box so that we can see. Some more people already answered, so I need to check the chat again there. Yeah. So people start answering. Okay, I start in the back column only there. Yeah. Okay. People saying this is typhoid only, despite the viral test is negative, and people put either the choice 3 or 4. Enteric is a diagnosis people considering, despite viral is negative. So they say spleen enlargement. If you say spleen enlargement or diarrhea, spleen enlargement can happen in variety of diseases like malaria, even dengue can have splenomegaly. Apart from the non-infectious etiology, the hematology course is also going on. They will discuss spleen enlargement and a lot of the hematological issues can come up. CLD can cause splenomegaly, and diarrhea also can happen in a lot of diseases there. So people are still putting number 4 or number 3 and diagnosis are making entering, but despite viral is negative. So good participations. So I'll come back and explain this case. What is the clinical clue? How we suspected this case and solve this case there. 1 second. Yeah. So the objective of these presentations, we don't have a lot of investigations or a lot of newer modalities to make a diagnosis in infectious diseases. We make infectious diseases diagnosis by simple history taking, simple physical examinations. We don't want any major tests or major extravaganza to make a diagnosis of fever diagnosis in your OPD. That's what we are basic aim, because most of the people are studying in a public sector hospitals and government hospitals. So we got very limited resources. With limited resources, how we are making a diagnosis. That's what our aim. So what I'm doing is the clinical clues, I put it this way. So what are the clinical clues we getting it? So this man is a young person. Usually people of less than 40 years, the chances of getting typhoid is very high. People above the age of 40, because of the repeated exposure, some sort of immunity would have developed. The chances of typhoid is bit low. Second thing, the person is staying away from the home and eating all sorts of food. Typhoid is basically a foodborne disease. So we need to know what sort of food the people are eating, where they're living. That's more important. Particularly if the person is eating outside food, my history taking should ask what sort of food is eating, whether the person is eating anything uncooked, anything unboiled, anything unpeeled. The chances of getting typhoid is very high. For example, vegetable salads, fruit salads, ice cream, juices, pani puris, chutneys, curd rice, whichever food is not cooked, not boiled, not peeled by you, the chances of getting typhoid is very high, provided if you are young, and the chances of not exposed to typhoid in the previous years, the chances are a bit high. And third thing, the typhoid, the fever can last longer, more than 7 days, not like viral fever. Most of the viral fever, the fever will subside by day 3, day 4, but here the fever can last longer. And second thing, the typhoid has got mostly intestinal involvement. So either the person has got diarrhea or the person might have constipation. That's called altered bowel habits. Spleen may be enlarged. I told splenomegaly, a lot of causes is there. I think clinical clue sessions in the afternoon, they will discuss about splenomegaly. Then no response to levofloxacin. Previously, people used to treat typhoid means either ciprofloxacin or ofloxacin. Of late, the resistance to ciprofloxacin, ofloxacin is very high. Why? This is called naldixic acid resistant typhoid. Previously, MDR typhoid was common, but nowadays we are seeing more of naldixic acid typhoid. What is naldixic acid resistance? Naldixic acid is a first generation fluoroquinolone. That is precursor of your ciprofloxacin, ofloxacin. When the person has got resistant to naldixic acid, ciprofloxacin, ofloxacin will not work. Only one floxacin will work, that's called GATI, because GATI needs two-step mutations. Unfortunately, gatifloxacin is banned because of the dysglycemia. So none of the fluoroquinolones is active against typhoid. That is one of the clue. So we need to know the history. When some practitioners prescribe some antibiotic outside, we need to consider what antibiotic the outside practitioner is given to you. Based upon the prescriptions I need to read, I can't ignore the previous person's prescriptions saying that just throw it. So always in history taking, elicit proper drug history. That is also more important based upon the drug. For example, if the person has taken azithromycin and more than 7 days, the fever is lasting, I can put my differential diagnosis of typhoid less likely, or choices 4 or 5, not number 1. But here the person has got choice of levofloxacin. That is why I consider typhoid. Already the fever is lasting more than 7 days. Young guy eating outside food, traveling, staying away from the home, all sorts of food is trying it. So the chances of typhoid is very high. This is how the clinical clue in history taking is very, very vital. So each and every bit you think this is not a big, very big important part, but that important the bits and pieces only make the diagnosis in infectious diseases. So if you elicit a history, the clue is always ask what sort of food, where they're eating, any travel, any exposures, any sick contact. These things is very vital in infectious diseases. For example, any sick contact, we always put some respiratory virus possible. And the person is visiting some rural part, a suburban part, the chances of scrub typhus or leptospirosis is very high on the card. So I'll show the next case here. 30-year-old male, diabetic, fever of 4 days durations. So all those who are logged in, please keep your choices in the chat box so that we need to monitor how many people are answering so that we can have some assessment of you, whether you are participating actively or your laptop is participating actively. We can able to make some judgment on you on this today's session there. So this is a 30-year-old male, diabetic, fever of 4 days durations. This is an high-grade fever with chills, body pain, back pain, headache, and vomiting. He was apparently normal 3 p.m. 4 days back. No sick contact. Recent travel to some hill stations. On examination is febrile. Vitals were stable. Rest of system examination was normal. His dengue NS1 and IgM test is negative. What is your clinical clue in your diagnosis? How many say young people? That's why this is a very important clue to me. Or this person is a diabetic, that is a clue to me. Or fever of 4 days durations, or the skin rash. Just go ahead and put it in the chat box so that we can discuss in the next slide how to approach this case in your private practice there. So I think people are putting skin rash is a clue here. Some other people are putting choice 3. This is previous only, I think so. I just want to update it now. So people say all of the above, or people put 4. So young individual or all of the above is putting it there. So apparent rash is not characteristics. So people put 4 or 5. That's very good participations. Thank you. So what we are going to do now, so dissect this case now. So what is the clue here? Sorry. So this clue is the person is young, yes, possible, but typhoid and dengue. Dengue is not no specific age group. Typhoid, I told, chances of less than 40 years, chances of getting typhoid is very high. But dengue, there is no specific clue. But children, the severity is very high. Possible severity is very high. On the other hand, age is not going to give any clue for dengue. Similarly, diabetic or non-diabetic, if diabetic person getting any infection, the risk of complications and severity is very high. Otherwise, chances of getting because of the diabetic and dengue, there is no correlations. Fever of 4 days duration, excellent clue. Most of the viral fever, I told, the fever is less than 7 days. By the time 7 days, if the fever is lasting more than 7 days, the chances of viral fever is less likely, except few viral infections like mononucleosis. So the durations of fever is a very good clue here. And second thing, sharp onset of fever. Most of the viral fever, the patients will give history. Doctor, I was apparently normal 3 p.m. That's a sharp onset. In typhoid or malaria, the people cannot say at what time the fever has started. So this is a very important clue, sharp onset of fever in infectious diseases. They point at time. I was apparently normal till yesterday morning. Till yesterday afternoon, they tell the thing. That's very, very important. And this rash is a diffuse rash. And if you see normal skin, that's called area of island. The person has got diffuse erythema. In between, the area of skin start clearing. That means first stage of dengue, the person has got diffuse erythema. Normal skin won't appear. But once the dengue start improving, normal skin start appearing in between this area. That is called area of islands. So diffuse erythema and area of islands is very typical clue of a dengue. So all of the above people put no. The timeline is very important. So here the clues are fever of 4 days durations, sharp onset of fever, characteristic rash. Based upon the thing, you can ask the dengue NS1 and IgM is negative. How can you make a diagnosis of dengue? You need to know the timeline of the test. For example, dengue NS1 forms on day 1 of the fever. It lasts up to day 4 or day 5. By the day, it usually lasts by day 1 to day 2. Day 3 onwards, start disappearing. In fact, some of the people, the NS1 start disappearing on the day 2 itself. So don't think NS1 remain positive on day 3 or day 4 of the illness. So we need to know the timeline when to do the dengue test. It's more important for you. So when the person has got suspected dengue, if you want to do the NS1 antigen, do it on day 1 of the fever or day 2 of the fever. Afterwards, the NS1 start disappearing. IgM is an antibody test. All antibody needs minimum 5 to 7 days for the body to recognize to produce antibody. So what happened if you do the test on day 3 or day 4 or even day 5? What happened? NS1 formed, disappeared. IgM still not formed. Characteristic features: sudden onset of fever, some rash typical, and rash also start disappearing. That is more important. So if you want to do this test, what is ideal? Ideally PCR. Nowadays dengue PCR is available. It can remain positive even for up to 7 days also, or even sometimes extend more than 7 days also. So if you think dengue and the person comes to you on day 3, day 4, so don't rely on NS1 negative and IgM negative rules out dengue. So that's a myth. So we need to know the timeline. Before the timeline, know the clinical history. Sharp onset of fever, less than 7 days of fever, and typical rash, diffuse erythema, or clearing skin in between the diffuse erythema. We need to think about classic dengue there. So the sign is called, I just put a word in a second. Yeah. So this is the initial stages of dengue, diffuse erythema. Just keep your hand, you can blanch the skin start blanching. So this is a sign of dengue there, but most of the time dengue, but sometimes chikungunya and Zika also have this type of presentations. In infectious diseases, we need to think broad. What else is causes fever? Suppose a dengue test is negative, even the PCR came back negative. Don't take it as don't take it as a the lab is wrong. So take clinical picture, think the differential diagnosis. Sometimes chikungunya, sometimes Zika, sometimes some drug fevers also can cause this type of diffuse blanching rash is possible. So this is what we need to keep in mind. So the history taking is very, very vital. That's the point I'm telling so far. Then history taking is a very vital thing. So always we need to know what sort of individual. For example, we need to know this individual. I told diabetic, the chances of complications are a bit high. Whether the person is from the rural background or urban background. Third thing, whether he's eating home food or outside food. Any travel he did. What sort of medications, whether any native form of medications, Ayurvedic medicines, Siddha medicines, and what sort of exposure, some sick contact, some pet exposures, drinking unboiled milk. All the things we need to know depending upon the history, depending upon the clinical case. Short febrile illness, always I want to know the history of sick contact or any travel recently for crowded places, particularly AC trains or something there, close to environment is traveling with some sick contact, the chances of influenza-like illness is very high. So history taking is a very, very, very important part as far as infectious diseases is concerned. So always spend some time. If you spend time, you can able to make a diagnosis of it. Most of the diagnosis is possible. That's the point we are talking about it. This is clearly told by one of the legends there. The differences between a good clinicians and indifferent clinicians, the amount of time what we spend in history taking. If you spend some good time in history taking, you can dig the answer. Infectious disease is nothing but taking a good history. If you take history, 90% to 95% of the problems is solved. Examinations is only I can put 10 to 15%. Most of the time history taking, that is more important. Try to figure out small clues from the history that will give you a better picture. That's what the first edition Dr. Professor Chandrasekhar was discussing. History taking is very vital in infectious diseases. Please take proper history. That's what he told. That's what I'm told. And second thing, we need to know some local epidemiology. Local epidemiology. For example, the study is conducted in Chennai. So when a person's present with less than 5 days of fever, what is most likely? Most likely it's a viral fever. Viruses may be influenza, maybe dengue, or maybe chikungunya. That is more common. Malaria is now coming down. Not common. In Chennai or in Tamil Nadu, I can put it, the malaria is not that common. But dengue is more common. Typhoid is common. Scrub typhus, leptospirosis, depending upon the season. For example, in the August to February winter season, scrub typhus, we have seen a lot of cases. Following a rainy seasons, we see a lot of leptospirosis. But malaria, we are not seeing more number of cases. When I was doing my undergraduations and post-graduations, more malaria cases, but now malaria is seeing less number of cases. So this is a one. And second thing, we need to know about the durations. Less than 5 days, there is no need for any specific test or specific antibiotic. Just give symptomatic therapy. This paper showed for a person on day 2, day 3, if the person is hemodynamically stable, you can wait, give some symptomatic therapy, observe the patients without any test, without any antibiotics. Most of the fever will subside, provided the patient should have hemodynamically stable, no localizing signs. For example, the person should not have signs of UTI, signs of meningitis should not be there. If the person does not have any localizing diseases, stable patients, 2 to 3 days of fever or up to maximum 5 days of fever, with symptomatic management, we can improve. That's what we need to know. So less than 5 days, young person, no comorbid, Vitals were stable. Symptomatic care is most important. With temperature chart monitoring can be ideal. Suppose you think the person has got typhoid, you send the cultures and start antibiotic. Your suspicion should be typhoid. Most of the fevers, acute fever, without any localizations, stable patients is viral fever according to our data. So this is what we need to know, how to take history taking in the proper. So the first part of my presentation is history taking in infectious diseases. Spend some time. Give minute details also there. Travel history, food history, sick contact history is very vital. So next part I'm going to share in a minute. 1 second. We thought of putting a questions in the each sections. I want to test the knowledge. That's why I put the different sessions. But unfortunately, the app was not for helping us. So that's why I put initial part is history taking. The second part is now the examination part. I'm going to focus now. Any questions, you can put it in the chat box so that we can discuss in the end or in between also we can discuss once the slide is opening up there. So this is like a clues in the examination part now. So what next we want to do? It's opening up there. Sorry, because of the history taking only I put that. This is third part. We got three parts today. First part is a history taking, second part is an examination, third part is an investigations. So far, that's what we discussed in our session so far. The second part we are sharing now. 1 second. Examination. So the next part is examinations. I hope my slides are visible now. Yeah. So what I am doing here in the examination part, I show a couple of cases here there. Sorry. Yeah. So this person is from again Southern India, 28-year-old male from Tirupati, very close to Chennai. Altered mental status of 2 days duration. AMS is called altered mental status. Sorry for using your short forms. Fever 3 days back, but the fever lasted only 1 day. Afterwards, the fever subsided. But once the fever subsided, the person started developing altered mental status, not able to walk. He is not from Pune, he is from Tirupati. On examinations, now sensorium is better. Fever is also subsided. The sensorium is also a lot better. Swelling and tenderness in the ankle joint, wrist joint, and knee joint is present. Rash over the nose. I put it in the picture also, the rash of the persons. So what is your clue you think here? So people start voting in the chat box so that we can have a better idea. What do you think about it? Very short fever is a clue here. Or not able to walk. So people think this is a Guillain-Barré syndrome, GBS. What do you think here? So just go ahead and vote so that we can have some discussions at the end. People start voting for. People say all of the above or the rash 4. That's a typical clue. They're thinking about it there. Okay, active participation is going on. Very short fever, they're not thinking about it. Not able to walk, altered sensorium. People think either the rash or the all of the above is the choices they're thinking about. So the clue is here, this is called brownie nose sign. Nowadays, people with chikungunya, the exposures, this is a classic presentations. So we need to know the localizing symptoms. Here, the person has got localizing symptoms, fever with polyarthralgia, but fever lasted only 1 day. Typical polyarthralgia, not able to get up, not able to move, and some amount of viral fevers can cause us altered mental status is possible. So the person has got encephalopathy presentations that start showing improvement in day 2 onwards. Similarly, the person is not able to walk, not able to get up, and typical rash. Why this part nose? Because this is the most exposed parts in the body. A lot of melanin depositions can happen, and body's immune system is also reacting. Nowadays, we got a name called brownie nose sign. That is one of the hallmarks. So when a person has got fever, polyarthralgia, polyarthritis, skin rash, we need to think about the presence of chikungunya. What is the clue? Short illness. Usually chikungunya compared to dengue or compared to Zika, the durations of fever is not great. Very minimal fever will be there. On the other hand, polyarthralgia, I showed the person has got joint pain, particularly involving both small joints as well as long joint, along with the skin rash manifestations. When a person has got fever, rash, polyarthralgia, polyarthritis, we need to think about of chikungunya. And this hallmark sign is very classic. People have seen a lot of cases during last couple of months when chikungunya was rampant, 3-4 weeks span. We need to know what we are doing with it. So the clue is fever is transient, mole of polyarthralgia, polyarthritis, and characteristic skin rash. That too, particularly involvement of the nose. We need to think about chikungunya. So that's most important thing. So if you do your proper examinations after taking a detailed history, if you do your proper head-to-toe examinations, most of the time we can able to figure out what is going on. So this next case here, again, this is a 42-year-old male from southern part of Tamil Nadu, farmer by occupations, 10 days of fever, body pain, back pain. He got cough with minimal expectations and he started developing shortness of breath. On examination, the person is confused, tachycardic, tachypneic, and hypotensive also. The person has got heart rate went up, the respiratory rate has gone up, BP is slightly on lower side. He got axillary node as well as inguinal node. On examinations, auscultations, crackles were hearing. On Cephixame was taking on day 7. So what is your clue here? So people need to vote whether farmer, that is a clue for you, or from southern India, that is a clue, or 10 days of fever, or the person has got because he got some cough, respiratory distress, he got some confusions, he got some hypotension. So almost majority of the organs are start affecting for this person's. That is more important here. The person is tachycardic, hypotensive, altered mental status, young farmer, 42 years old farmer. So what do you think? That is the reason for it. Or the person taking day 7 of Cephixime. So what are all the diseases we are here ruling out? Can anyone tell what are the diseases we are ruling out here? With this history, these things is not likely. So I just examine the possibilities. So put it in the chat box so that we can discuss at the end what are all the diseases is unlikely to happen. So the person is putting scrub typhus is more likely. The choice is 5. 7 days of Cephixime. Some people put day 3 and day 4. Somebody thinking about milioidosis says 1, 2, 3, 4. Somebody says brucellosis. Very good differential diagnosis people are offering because of the rural background, farming occupations, exposure to the animals. So these are all the historical clue. Southern India, what are all the diseases is common in Southern India? What are all the diseases? We see a lot of Northeast populations. For example, histoplasmosis is more common in Assam, Tripura, West Bengal belt is more common compared to southern part of India. But southern part of India, scrub typhus is more common, I agree. But nowadays, scrub typhus is seen across India also. That's not a different story. But compared to northern part, scrub typhus is more common in the southern part. And couple of infections like the histoplasmosis is more common in the northern part. And similarly, farmer occupations, exposure to the animal as well as exposure to the agricultural field. People thought of milioidosis because farmer exposed to the agricultural field. And Cephixime is going on. Cephixime is not a good drug for milioid. And similarly, Cephixime is a good drug for typhoid. Cephixime is a good drug for your leptospirosis. So a person taking more than 7 days of Cephixime with a good doses, still fever is present. The chances of typhoid or chances of leptospirosis is unlikely. The chances of typhoid or leptospirosis is unlikely. That we need to keep in mind. So the chances of scrub typhus is possible. Scrub typhus and leptospirosis closely mimic. Again, forming proportion. People with the southern India background, forming occupations, fever is lasting possible with both scrub typhus and lepto. What is the clue to differentiate whether this is not leptospirosis? The clue is Cephixime. Not only doxycycline, not only crystalline penicillin, even third generation cephalosporin like Cephixime, third generation cephalosporin like ceftriaxone will work for your leptospirosis also. So that is a clue why leptospirosis is not a differential diagnosis here. So keep in mind these things. So we need to examine the patient properly. So we did the examinations of the patients. Beautiful head scar is present on the thigh region. Most of the time, the head scar is present in the thigh region, particularly for male, because we use tight garments. Wherever the tight garments we are wearing, some moisture will present. The mite can climb with your dresses. The bite of the mite is very painless. Don't think if the bite is painful, people will complain. Most of the people, they won't complain. Particularly female, they say, I work in the kitchen, some oil was splashed on me. That's what the female history will give it. They ignore this type of nagai rashes. And this is present in personal parts like the breast below. Females, it is more common around the breast or axilla. People don't want to tell also because of the stigma associated with it. They don't want to reveal it. Similarly, male person's scrotum, genital, thigh region is more common. They don't want to tell also. This is a reason. So we need to examine the patients from head to toe. Ideally, we need to strip the patients. If it is a female patient, please keep some female attendant along with you while examining the patient. That is more important. So examine the patients. If you find the head scar, most of the time head scar is single in scrub typhus. Black necrotic surrounding erythema. Classic head scar I have shown here. Black necrotic part surrounding by some erythema is present. Usually in the male persons means below the umbilicus, female persons means above the umbilicus, 30 centimeter below the umbilicus, 30 centimeter above the umbilicus. We need to think about it. So this is a part we need to examine. What is the clue here? Person from southern India, formed by occupations, fever lasting more than 7 days. Person has taken Cephixime with no responses, multi-organ involvement because the person was not treated with appropriate antibiotic. It can affect your respiratory system. It affects your meningeal system. It affects your kidney. It drops your platelet count also possible. So we need to know what we are dealing with it based upon a good examinations. So I'll show a third case here, 40-year-old male, rash 7 days durations. Initially some feverish feeling, body pain, now rash I showed in the picture. Past medical history, nothing. He got extensive travel. He's businessman by occupations, travel extensively India, both northern India, southern India, eastern India, western India. All parts is traveling, every week is traveling. He had extramarital contact 1 month back with commercial sex worker. On examination, is afebrile, rash on the left side of the neck. Rest of the system examination was normal. Friends suggested because he got a businessman, he got of local contacts. People said that time monkeypox was rampant. That is 2022, 2023. Monkeypox was rampant. His friends are very well educated. Go and check monkeypox is present or not. You had commercial sex. That's what people are telling. So what is your clue here? People start voting so that we can have discussions. Rash or extensive travel or extramarital contact. What do you think? What do you think? I think people are answering a lot. Very good. 1, 2, 3, extramarital contact. Very good. People thinking the extramarital contact is a good clue here. Fine. Okay. So people thinking about extramarital contact, but most important thing, that point of time, so far monkeypox cases has not been reported. That's most important thing. We need to know the local epidemiology. That's why I said in the history part, we need to know the local epidemiology. This may be the first case of monkeypox, I agreed. But that point of time, there's no cases. But nowadays, we not call monkeypox as monkeypox. This is called mpox nowadays. The terminology is also changed. So need to update the terminology. That is why this short certificate course is going to help you out. Know the new terminologies, know the new diseases, what is happening. So we need to know when the person has got rash, the differential diagnosis should be always broad. How to differentiate mpox from chickenpox? Mpox, the rashes can involve the palms and soles, but chickenpox, the rashes is not involving their palms and soles. The way it is spreading, it is centripetal distributions or centrifugal distribution, that is more important. And the rashes of chickenpox has got different stages. For example, some lesions may be papule, some lesion may be vesicle, some lesion may be macule. But on the other hand, some lesion may be scabbed out also. But monkeypox, it grows in the all lesions can grow in the same group. For example, some are papules, all the lesions are papule, then change it to vesicle, then finally they scab out. That's possible. So we need to closely examine the rash. That's most important part. But unfortunately, people are not examining the rash most importantly. And we need to know which part of the body the rash is present also. That's why I said, if it is sparing the palms and soles, whether it's involved the mucosal surfaces, very vital. So don't think when a person shown one rash, examine that part and ignore the other part, you're not going to make a diagnosis. See the rash and correlate with the fever also, whether the rash preceded fever or fever preceded rash, which part of the body it is involved, what sort of rash, whether it's a papule, vesicle, or whether the person has got scabbed out lesion, that is more important. Suppose a child that got this type of lesions, we can put immediately molluscum contagiosum as a lesions. But when the person has got extensive travel outside India, that point of time, because mpox not happen in India, it's outside India. So we need to know this type of umbilicated lesions, the differential diagnosis, either mpox in children, mpox in adult, molluscum contagiosum is in children. People from the northeast, we can think, for example, the person is immunocompromised, cryptococcosis is possible. A lot of renal transplant patients and other transplant, we see this type of lesions. And one more fungus is called Penicillium marniae, particularly HIV patients from Assam or the northeast populations. We need to think about Penicillium marniae, depends upon the immune status of the patients. So the rash with immune system, along with exposures, which part of the body it is involved, we need to examine the person as a whole, not as a part. That's the point I'm making here. So we need to know, for example, this case, this person traveled internationally. For example, he went to Nigeria initially, then went to US and stayed in the ship for a long time. So he got men with have sex with men. Usually mpox cases more with homosexual compared to the heterosexual contact initially. Later it spread heterosexual, but men having sex with men, that has got more relationship. So we need to know this type of history, whether the men having sex or women having sex or heterosex, we need to know. That is more important. What sort of rash, that is more important here. Umbilicated nodule, this type of lesions is very important depending upon the immune status. If the HIV positive, my diagnosis is cryptococcosis. If HIV positive from northeast, my diagnosis is Penicillium marniae. If it is a child around the face, I put molluscum contagiosum. So it depends upon the age, depends upon the populations, we need to make a diagnosis here. And we need to know who is going to develop mpox, who is not going to develop mpox. That is more important for you. So keep in mind these things. So we need to know which populations. For example, some of the healthcare workers, without knowing these things, they can handle it. The chances of picking up this type of cases is very high, particularly herpes lesions. Herpes whitlow can happen in your fingers. Without knowing what is the lesions, you start examining the lesions without proper PPE. So this type of infectious diseases, not only the history taking, not only the physical examinations, but also think about whether you are going to get the infections by handling the patients. So wear appropriate PPE, wear gloves and examine. Don't touch. For example, syphilitic lesions, people handling without glove. So always wear appropriate PPE before examining this type of patient. That is more important. So second part in infectious diseases is do head-to-toe examinations. Some of the lesions is not shown by the patients. Some of the lesion they are not going to discuss with you. So we need to dig out the physical findings. And third thing, the physical findings should correlate with the epidemiology, correlate with the host, and other parameters also we need to consider. Don't consider that one physical finding alone to make a diagnosis of it. So this is very important. So at the end of history and physical examinations in infectious diseases, we need to know what is a syndrome, whether we can able to come with some syndrome or not. For example, when the person has got fever, headache, altered mental status, I need to say whether patient has got meningitis or meningoencephalitis. Similarly, fever, running nose, sore throat, hoarseness of voice. Think of URI, upper respiratory tract, either pharyngitis or laryngitis. Similarly, fever, cough, shortness of breath, pneumonia syndrome. So always try to localize at the end of your examinations after taking the history. Try to put some syndrome. Some of the syndromes is not possible. For example, I have shown a couple of cases, fever with polyarthralgia, fever with skin rash. This type of syndrome is possible. But the case, for example, the person I've shown the scrub typhus case, it doesn't fit into any syndrome. Fever, some altered mental status, cough. So it overlaps, its true syndrome is possible. Similarly, the first case, fever with the diarrhea also does not fit into any particular syndrome. Try to make a syndromic diagnosis. If sometimes the syndromic diagnosis is not possible, we need to think like other possible options also we need to think about it. So try to make some syndrome at the end of your examinations. This is one of the beautiful infographic prepared by BMJ for a country like India, tropical infections. For example, if it is malaria, what are all the possibilities? Usually the malaria, the person might have pallor. Malaria, the patients admit pallor. Similarly, for enteric fever, splenomegaly, but even though the typical like a spotted tan that won't happen, leptospirosis means subconjunctival congestions. Dengue means retroorbital pain, diffuse blanching rash. Leptospirosis again, jaundice, ictus can present, Weil's disease presentations can happen. So we need to know which disease has got more presentations. Scrub typhus, regional lymphadenopathy can have. The case what I shown, regional lymphadenopathy, HCAR. So we need to know the classic physical signs for each and every diseases and try to find out the diseases that is more important. So physical examinations in infectious diseases, even though it contribute 10 to 15% of occasions, but help to cleanse the diagnosis, do proper head-to-toe physical examinations, focused examinations. Depending upon the history, we need to do the thing there. Now we are going to show the last part of my presentations, how the investigations in infectious disease is going to help out. So we need to know. So far, Naga, your participation is good. So we are going to keep Naga porting a lot of cases in the last part also. So how to make a diagnosis here. So you want to have any questions, please put in the chat box so that we can discuss towards the end. I can take another 15 minutes and we can discuss the thing there. Fine. Sure. Yeah. So this is my third part of the investigations because I split this Naga part to keep the polling, but unfortunately it was not worked. So this is a 62-year-old male, diabetic, interstitial lung disease, 20 days of fever, dry cough, weight loss of 4 kilograms, taken on and off steroids for the underlying ILD. Sugar was poorly controlled because he was on steroid. That's why he keep on stopping the steroids and taking the steroids on and off. He used to consume alcohol also. So based upon the CT imaging was done, showed a cavitatory type of consolidations. So people did and MAN2 was strong positive. Then they did the bronchoscopy, but unfortunately the CB-NAT came back negative. So what is your clue and what is your diagnosis here? So the clue, whether people say 20 days of fever or systemic symptoms in the form of weight loss or steroid intake, what do you think the person is a clue for you? MAN2 positive, that's his TB, poorly controlled diabetes, or CT scan, cavitatory type of consolidations in upper part of the lung. So what do you think? I want to see the responses of the people here. One second. People say steroid intake. People say poorly controlled diabetes. This is TB. Some people say nocardia is possible. They're thinking differential. So that's one of the point I told you there. In infectious diseases, keep your differential diagnosis broad. Don't stick to the one diagnosis, particularly when some of the key investigations is keep negative for you. People are putting the clues, but what is your diagnosis? People answer, start your diagnosis. What is your diagnosis here? People say aspergillosis, people say fungal infections, people say TB, not hitting the nail. Yeah, okay, go ahead. So we will put aspergillus, fine. So, okay, so we need to know these are all the diagnostic clues for a tuberculosis. Poorly diabetic, poorly controlled diabetic, ILD with some steroid intake, the chances of tuberculosis is very high. Man2 says whether it's a latent TB or whether TB is present or not in your body, that's infected or not infected. That means whether the person has got latent infections or not. It will not say 20 or 25 millimeter or 30 millimeter, will not say whether the person has got active TB. That is more important. So this is most likely the person has got a latent TB if MAN2 is positive. But MAN2 cannot say whether the cavitated pneumonia is because of the MAN2 positivity there. But the BAL CB NAT, because bronchoscopy has got a very good heal, particularly CB net, the yield is more than 90%. Despite 90% yield, despite the risk factors is present, taken so much of steroids, underlying ILD, definitely the BAL should have positive. But once the BAL is negative, we need to think about what I am missing out. So we need to think here, your diagnosis is pneumonia. Cavity type of pneumonia syndrome, particularly subacute. What is the syndrome at the end of my physical examinations and history? Subacute cavity type of pneumonia. Subacute cavity type of pneumonia in a diabetic host, particularly from India, the differential diagnosis is TB. Whenever we think TB, the fungus means histoplasmosis is more common, particularly northeast, but southern also we see a lot of cases of histoplasmosis. Then third thing is called milioid. Fourth thing, other invasive fungal like aspergillosis is possible, but milioid is more likely here because of the diabetic, because of the steroid intake, because of the alcohol consumptions. So we need to think about it. Once the bronchoscopy is negative, we need to revisit our diagnosis. I'm not saying like always like tuberculosis, we can get expert positive, AB culture positive. That is not the case. But we need to revisit the diagnosis once the bronchoscopy ball is negative, whether am I missing something else? That is why infectious diseases always think broad. Don't think narrow. If you think narrow, some of the important tests like bronchoscopy came back negative. We need to reassess what I'm missing it. So this is our own data we published in 2013. In fact, we won the prizes also from the J.C. Patel and P.C. Mehta award we got for this paper for original research in 2013 there. So what is our original research showed the milioidosis? When a person has got fever, when a person has got alcohol consumptions, when the person has got CKD, whenever you think abscess, whether the lung abscess, whether it's a splenic abscess, prostatic abscess, parotid abscess, or the person has got diffuse subacute pneumonia, we need to think about milioid. Milioid is possible, particularly agricultural background, following floods. For example, Chennai has got a major floods in 2015. Following floods, people expected leptospirosis, but we saw a lot of milioidosis in 2015. So we need to know when to suspect these type of diseases. That is why I said keep differential diagnosis broad. So I'm showing another case here, 30-year male, no comorbid, left-sided swelling. So this is basically a cervical lymphadenitis. That's my working diagnosis. Left-sided cervical lymphadenitis. Again, if you did necrotizing granulomatous inflammations, but this time MAN2 is negative. That is why I said MAN2 has got so much of limitations. Don't go with MAN2. For example, people want to do quantiferon gold, TB gold. Quantiferon TB gold is a glorified MAN2. So put your clue. What is your clue here? Because we want to discuss and we want to finish it off there. People, for this case, I want to see. Last time they said aspergillosis TB. So this time they're saying people crypto TB. People start answering. So number 4 is a choice, but what is the diagnosis here? Put your diagnosis here. People say TB. Necrotizing granuloma means TB. So people think like a histopathology flu chase is a classic feature. That is why TB is diagnosed. So always a common mistake people think necrotizing granuloma, people think always TB. But usually when necrotizing granuloma is present, the differential diagnosis is broad. I'll show in a minute. These are all the differential diagnosis for granulomatous lymphadenitis. So don't say necrotizing granuloma is equal to TB. Non-TB mycobacteria can behave. Sometimes sarcoid, even though it's not necrotizing, I know granulomatous lymphadenitis, but sometimes it's very confusing pictures. You can have Yersinia, cat scratch. A lot of diseases can confuse us with a TB. So while concluding before TB, particularly expert MTB is negative, when we want to start at ATT, you need to mention minimum, particularly if it is a female patients, ideally do ANA and dsDNA because connective tissue diseases can mimic necrotizing granuloma. Don't think necrotizing granuloma is equal to TB in particularly female patients. Male patients, the chances of SLE is bit less, but here it came as positive. So rule out these causes and always say it's necrotizing granulomatous lymphadenitis. Don't write TB lymphadenitis. Necrotizing granulomatous lymphadenitis, probable TB. If your ANA is negative, dsDNA is negative, it's a probable TB. I'm starting trial of ATT. I'm starting trial of ATT. These things is required to protect you legally. You can say, you can't say TB lymphadenitis. If the legal court asks where is evidence of TB, you start, when people go and find out this paper and showing granulomatous lymphadenitis or necrotizing granulomatous lymphadenitis, the differential diagnosis is huge. They can pull this paper and put it in against you. So always write necrotizing granulomatous lymphadenitis, probable TB. I'm starting trial of ATT based upon the clinical picture, based upon the histopathology. If it is female, ideally do ANA, dsDNA, make it negative, then you can start thinking of TB medicines. So before starting medications, think 10 times before because we are living in the era of a lot of legal litigations and everything there. So this is my last case for today. 30-year-old male from Salem, driver by occupations, skin lesions. I'll show in a minute with itching. So this is on and off diarrhea, weight loss of 3 kilograms. What is your CC, clinical clue? What is your diagnosis here? The clinical clue, how many people say this person is from Salem? That is my clinical clue. Salem is a lot of lorry transport is happening there. The Namakkal belt, lot of lorry transport. That's the area in Tamil Nadu. Lot of lorry transport is happening. Driver by occupations or skin lesions. Just what is your clinical diagnosis here you're putting here? Just I want to see the responses before I go to the final part. All are clear as atypical infections. Once again. What is the diagnosis here you're putting? So I can't see, can't go below. No messages. Okay. People say syphilis, driver by occupation, syphilis, HIV. Okay. So can you call this person classic presentations, driver by occupations from Salem, built a lot of lorry transport going for a long distance driving and skin lesions. This is called papillary pleuritic eruptions. Classic papillary pleuritic eruptions in a young male driver by occupation staying away from the family, driving for a long distances. Naturally, he is vulnerable for HIV, probably, but I can't make a clinical HIV. Even though the suspicions of HIV is very high, I need to do the laboratory investigations. Similarly, TB also we need to do majority of the time confirm previously based upon the cavitated pneumonia, start TB medicines. But nowadays we want to prove laboratory wise. After doing a proper history and examinations, certain diseases needs lab investigations. For example, this person examined properly. He got some Kaposi sarcoma like presentations along with papillary pleuritic eruptions. So Salem, the area for lorry transport, lot of HIV cases reported initially in our part. Lorry driver staying away from the family, classic papillary pleuritic eruptions, and people sometimes KBs can confuse with you, but after responding with ivermectin, the response should happen. Here, the response is also missing, and the lesions in the oral cavity, like Kaposi sarcoma, like presentation is there. We need to make our diagnosis, but we need to send the lab test. HIV is mandatory. I can't make a clinical HIV, even though clinical suspicion is strong. I need to demonstrate HIV positivity, then only I can start ART. I can't start ART without my clinical diagnosis alone. So certain diseases we need to prove. Unless I need to prove, I can't start the medications. Even though I can make a diagnosis of HIV, I can't start it. That's what's more important. So in short, when a person has got PUO, we can call juram in Tamil, juram of unknown origin or pyrexia of unknown origin. We need to call day 0 to day 3. The person is stable, no localizations, do not do any test. If the fever is lasting more than 3 to 7 days, do some basic tests like CBC, LFT. If the fever is lasting more than 7 days, we need to do blood culture. What test has got very limited role? Vidal is useless to me. Man2 quantiferon gold is useless. Leptomat useless to me. One bottle of blood culture. If you want to make a diagnosis, 2 bottles of blood cultures, minimum 7 to 10 ml. We discussed in our microbiology and clinician part. Urine cultures without urine routine. Always urine routine we need to send. When urine routine shows pus cells, then read the urine cultures. When the urine routine does not show pus cells, urine culture more than 1 lakh colony, it has got very limited value. So these things we are not doing it. Lot of tests. In fact, one recent publication called from clinical microbiology and infectious diseases, the test called ESR and CRP, they call zombic tests there. They have got very limited role. Vidal, why it is very useless test? Lot of false positivity. Lot of false negative. For example, E. coli in the blood can cause false positivity. Dengue can cause false positivity. Then what is a significant titer? We do not know. How long after typhoid is going to last? We do not know. So single Vidal is a useless test. We need to wait for 5 to 7 days. And one more test at 10 to 14 days to make a diagnosis. None of your patients can wait for 10 to 14 days based upon Vidal to make a diagnosis. That is why WHO says this is a useless test, single Vidal. Do not do Vidal test. What is the take home of this case? Do not do Vidal test in a practice to make a diagnosis of typhoid. Then how to make a diagnosis of typhoid or how to suspect. If you do in a good laboratory, your CBC is normal, neutrophil count is normal, eosinophil count is 0, ESR is normal, young individual, eating outside food, you can make a diagnosis of typhoid most of the occasions. If the tests happen, eosinophil count 0, neutrophil count normal, ESR normal, WBC count normal, young individual, less than 40 years, I can make typhoid based upon this rule 90% of the time. This is more sensitive compared to your Vidal test. That is why we never do Vidal in our practice. And this is a simple algorithm we use to make tropical infections. We do CBC. Hemoglobin is low, malaria. Hemoglobin is high, dengue is possible. Hemoglobin normal, typhoid, scrub typhus, leptospirosis. Then do the WBC count. WBC count is elevated, leptospirosis and scrub typhus is possible. WBC count is below normal, dengue or typhoid. Similarly, we see the platelet, most of the infections, malaria, dengue, typhoid, scrub typhus, lepto, all platelet will be low, but dengue, the platelet count is too low. Malaria and scrub typhus is between 40,000 to 60,000 most of the occasions, but in the scrub typhus and leptospirosis, it can go up to 60 or 80 also. Very mild reductions is possible. Do the LFT. OTPT elevated more, that is called hepatocellular pattern, that indicate the person has got typhoid and dengue. Alkaline phosphatase, GGTP, cholestatic picture, leptospirosis or scrub typhus. So we need to know malaria means peripheral smear. Don't make clinical malaria. Previously, people say clinical malaria. Now the term clinical malaria is not existing. Typhoid means either eosinopenia or blood culture. Vidal test is not existing. Scrub typhus and leptospirosis is a clinical diagnosis because I need to wait for 5 to 7 days to make a diagnosis of it. Influenza, rapid test has got very limited role. PCR is ideal. Dengue nowadays, PCR has got value or NS1 test or zero conversion. That is also value. TB means PAN2 and quantiferon has got no value. Expert MTB and AB culture. HIV means fourth generation ELISA. Urinary tract means symptoms plus urine routine plus urine cultures. Acute gastroenteritis, either stool routine or you can go with a molecular panel test. That's what we need to do. Always keep in mind before order any investigations, the person should save the money. Whatever way they came into your hospital, they need to go with some little bit of money, even though the person survive, but you need to have money to live. And this week, like a Monday, because of World TB Day, we are doing on interesting stuff because we do a lot of AI related things. So those who want to join web link, like we are providing the Zoom link also, or you can contact this WhatsApp number. We can provide you a link. This is happening on Monday, 1:30 to 2:30, where we are putting practical TB cases. If you want to join as a panelist, welcome. Or if you want to discuss some difficult cases, get opinion from our AI. Yes, the AI can provide you some support to you. Please join there. This is an initiative of Clinical Infectious Disease Technology and ID Subcommittee. Along with Apollo Hospitals, we are doing this one. And one day CME algorithms. So this is algorithm based CME is coming on 26th of April, not 26th of March, 26th of April. Only algorithms we are discussing, not anything there. For example, fever with rash, fever with jaundice, fever with altered mental status, algorithm for OP antibiotics, algorithm for IP antibiotics, ICU antibiotics, AGE, how to select the vaccinations, all our algorithms we are discussing. Those who are interested, please join or send the SMS to the previous number what we have provided. So this is a group teaching daily basis. This is a number you can send for both the Monday CME 2 days later or next month CME, please join it. I think I limited for like a 5 minutes for discussions, but no problem. We can put it so that all the questions will send by the organizers to me. I can reply leisurely. A lot of study materials we are planning to post to you there. Please feel free there. So everybody posting in the chat box column, picking up some of the cases and I'll start answering now. Can I get today's PPT? Yes. If you are a registered the PG, we can post it in the group so you can get it. Algorithm in the CME is an hybrid CME, ideally happening in Chennai. If you want to come in person, that's better. Otherwise, we can provide you hybrid also. Algorithm CME online, same thing there. It's like a both hybrid only. We are planning it there. That is on 26. It's happening. Should we treat leptospirosis on the basis? Yes. We need to make a clinical diagnosis of leptospirosis based upon the history, walking in the rainwater, wading in the rainwater, or agricultural exposures. WBC count elevated, platelet is bit low, jaundice, hepatocell cholestatic pattern, leptospirosis. Better to give because we need to do the PCR. PCR is now available. If you are able to do PCR, that's fine. Otherwise, serological test, we need to wait for 5 to 7 days, bit difficult. Can we get typhi.igm? Typhi.igm again is a serological test. We need to wait for 4 to 5 days. Typhi.igm is mostly specific for Salmonella typhi. It won't pick Salmonella paratyphi, but where I use Salmonella typhi test, it has got very good negative predictive value. On day 4, day 5, if you do the typhi.igm, if the typhi.igm came back negative, it essentially rules out typhoid, but it essentially does not rule out paratyphoid. So that's like a more important. So post post sepsis syndrome is equivalent to septic encephalopathy. No, during sepsis itself, people got encephalopathy. That is one of the multi-organ dysfunctions people usually encounter. That is possible there. So I don't think so. Like a post sepsis, only the encephalopathy should happen. It should happen even during sepsis. Because I want to cover all the three: history taking, physical examinations, and investigations. Kindly share the record. Yes, they are recording the lectures and posting in the YouTube, so you can go through leisurely there, whatever. Because the last part only a little bit fascinating, because unfortunately I need to cover all the three. So far, people missed the first 4 sessions. You can get the glimpse of what is happening in the infectious disease Naga certificate course. That's why I put it. So we are getting the record YouTube link. They will provide you there. So people who are registered for the short certificate course, the YouTube link will be provided. You can go leisurely and you can put the questions in the WhatsApp group what we have created. So your questions will be answered in the YouTube also. There's no problem in posting your questions and answering this uh, webinar Naga to the YouTube. So we are in the last 2 minutes of our time there. So we want to stick to the time because Kamlesh Tiwari sir was very, very strict on timing there because we want to wind up on right time at right time. We want to finish it off there. I hope sir is still like logged in there. So that you can contact the Naga organizers there. So you can message you as the organizers are seeing that thing. I do not know because right now the first part is over. This is a 20 weeks course. The 20 to 22 weeks we are planned right now. Already 4 weeks has been over. I started on February 5th. February onwards we started the thing. I'll check with the Naga organizers and get back to you there. How to join the course people are asking. But I'll check with the organizers whether it's possible at this point of time because you lost sufficient time. But we just check. Yeah, a lot of people are asking about it. Okay, last minute. So I asked Dr. Tiwari sir to give his words of wisdom, sir. Tiwari sir? I think Tiwari sir has some issues in right. If Tiwari sir is not there, I sincerely thank again his APA as well as ICP chapter for giving this wonderful opportunity to coordinate this course of infectious disease, short certificate course of infectious diseases. A lot of people are asking how to join and how to register. No worries. We check with the ICP, Indian College of Physicians office to I'll ask the office bearers as well as Tiwari sir to check whether it's possible because already 4 or 5 sessions is over. But I'll just check with him whether it's possible now because we need sufficient attendance also. We decided some sufficient attendance. Suppose people joining late, we need to think about it whether they compensate the attendance or whether we can do some mop-up sessions to pick up those people join late or those who miss some sessions also. We are working on it. We'll get back to the thing. If no things, then you can send whatever messages there. I sincerely thank all the participants as well as once again, I thank APA as well as ICP and particularly Dr. Tiwari sir for giving this wonderful opportunity. Thank you. So time is 8:30. We can close the sessions. Those who want to join, I given a WhatsApp number for Monday CME also, the tuberculosis CME. You can join both. That's hybrid mode only. Those who want to come in person, come to the Habolo Chennai, or those who want a hybrid, that's fine. Put whatever cases you got difficult TB cases, please put it to the WhatsApp number we provided so that the case can be discussed. You can join online. And second thing is the next month CME algorithms in ID. That is also a hybrid event. Those who come in person, come to the Chennai. Those who join hybrid, that's also fine then. Thank you. I am logging out there.